Good morning, everyone. We warmly welcome you to the 220th session of this weekly Sunday webinar series organized by the Society for Health Research and Innovation. Today's lecture is about understanding lumbar spinal stenosis. But before moving on to the lecture, let me remind you again some of our housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. for you all to join in, and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and these CPD points are strictly adhered to the NCCPD guidelines. We thank you for your compliance and your strict adherence to these CPD regulations, as they are maintained to improve the standards of the CPD programs conducted by the SHRI. Regarding asking questions, there will be a question time at the end of each webinar. You can type your questions in the chat box and set your settings to all panelists and attendees. If you have any specific questions, you can email us on office313@gmail.com. So for today's lecture, it's about understanding lumbar spinal stenosis. And the lecturer for today is Dr. Shazar Hameed. He's a consultant orthopedic surgeon at the teaching hospital, Pathophysiology. He has done his MD, MRCS, and a fellowship in spinal surgery at the United Kingdom, and has a special interest in pediatric and adult spinal surgery, complex trauma surgery, arthroplasty, and musculoskeletal tumor surgery. We warmly welcome you to conduct today's session. Over to you, sir.
So good morning, everyone. Okay, so just before we begin our lecture, so I think you thank the Shri Academy for giving me this opportunity. So I think I presented a previous lecture on cervical myelopathy, which is also degeneration related. To give a sort of a preview to the lecture, now I spoke regarding cervical myelopathy and degenerative cervical spine previously. I'm going to speak to you about lumbar degeneration today. There is a reason why the cervical spine and lumbar spine is associated with degeneration more than the rest of the spinal element, notably the thoracic spine. So that is predominantly because now these are your neck and the lower back is what moves a lot. So whatever moves is susceptible for degeneration. All right. Okay, so we've got, I think on our day-to-day practice in whatever we do, we get a lot of patients with back issues. I think even if you're at a GP practice, at the PD level, or in the wards, back pain is extremely common. And understanding how to address back pain and how to evaluate patients with back pain, and especially degenerative lumbar issues, is very important. So we will go through our presentation. I'm going to share you my presentation. So lumbar spinal stenosis. So before I begin, I will start with a brief case which we operated recently. So this was a 62-year-old female. The only comorbidity she has, she was a hypertensive. Otherwise, she was fit and well. So she had a history of back pain and leg pain for more than a year's duration. So she complains of back pain along her legs, numbness and weakness, especially when she's walking and standing. And overall, this had marked limitations of her capacity to stand and walk. She had no upper limb symptoms. On examination, she had very painful back movements. The stretch tests of lower limbs were negative. There was no evidence of cervical myelopathy, and the lower limb neurology was normal for tone, power, reflexes, and sensation. Now, if you have a look at her x-rays, well, before we know, not all of us have access to MRI scans straight away. So the first tool of investigation would be a simple lumbar spine x-ray. So obviously on a sort of a brief glance, you can have a look that it's quite different to a young spine, obviously. And there are a lot of degenerative changes. I will specifically tell you what we are looking in a spine, what we denote as degenerative changes. And one marked change would be if you check on the lateral x-rays, you could see that the L4 vertebra has slightly slipped forward in comparison with the L5 vertebra. And when you compare with the joints above at the back, these are called the facet joints. You can see the facet joints and the whole complex at the back at this junction is quite large, so hypertrophied, or some degeneration is happening at front and back both. So you do an MRI scan, the fact that one bone is slipped over the other is quite marked. Now we call this spondylolisthesis. And then you also can see the resulting pressure has squeezed out the disc backwards. And at the back, I believe you can see my arrow key, which notices quite a bulky black spot here. This is the hypertrophied ligamentum flavum, which is very thickened in a canal stenotic patient. And if you take an axial section, you can see the cross section, the nerves and the cauda equina are hardly visible. It's a severe canal stenosis. On top of it, if you check the facet joints at the back, they're quite large. You can see they're not very uniform. There's a lot of bony spurs. This is a feature of an osteoarthritis of the facet joint, which also happens to be a synovial joint. And also, if you note, there's a lot of whitishness inside the joint here. So this is a sign that the facet joint is quite unstable. So it also says that if you do any procedure at the back to relieve the compression on the nerves, you will cause further instability. So you got to take measures regarding that. If you also check the level below, you can see there is compression. Now, how you say is like now here you can see the cauda equina, and the dots inside are the nerves. Generally, you do an MRI scan, the supine position, and you expect the nerves to sediment down. By the presence more anteriorly, we can diagnose that there is canal stenosis at that level also, right? So what we did surgically was, the principle is to relieve the tension of the nerves. So the whole procedure was called L4-5 transforaminal lumbar interbody fusion and decompression at L5-S1 level. Right, fine. So what we basically did was, as I mentioned you before, the L4, L5 level was quite unstable. We put metal work into that, and we removed the whole back of the vertebrae, which is called a laminectomy. We removed all the facets and the thickened ligamentum flavum and removed the disc material, put additional support from the front, and also we went to the level below. We decompressed the level below. So this is classically what we do, right? So this is how it looked like after the surgery. So you can appreciate what we have done in terms of the metal, but what is not visible is the decompression work we did at the back. So that's a classic case scenario, how it goes by. So what is lumbar stenosis? It's basically a circumferential narrowing of the nerves in the lumbar spine, which leads into stenosis of the neural element. Okay, it can be associated with spondylolisthesis, which is like one bone can be slipping in comparison to the other forward, or you also can have sideways bending, which is called scoliosis or degenerative scoliosis. This is different to what we have in adolescent age, which is called adolescent idiopathic scoliosis. So the prevalence, well, we don't have quite a strict figure, but like one of the famous studies, which is called the Wakayama spine study, based in Japan, has revealed us the prevalence to be somewhere around 9.3% and the mean age to be around 66. It's quite significant. So recent estimates also suggest that about 1.4% of Americans over the age of 65 undergo spine surgery for lumbar spinal stenosis. One other famous trial called the SPORT trial has identified that the mean age to be around 65, more males are affected, and high BMI and Caucasians are a predisposing factor, right? I'll briefly tell you a little bit about the anatomy of this lumbar spine. It will be very important because now we need to identify the anatomy and the pathological process and correlate it with the symptoms. That is when we know where the problem lies, and it will help us to extrapolate it to what needs to be done from a surgical or a conservative point of view. So there is a front element in the spine, each vertebrae, which is composed of the vertebral body and the intervertebral disc. As you know, the intervertebral disc is composed of two elements. There is in the center what we call is the nucleus pulposus, and it's surrounded by the annulus fibrosus. And the posterior element is composed of the pedicles and the two lamina, which converge into the spinous process. So within this, it encircles the neural canal or the central canal. So the central canal is surrounded by the vertebral body anteriorly and the disc, the pedicle and the lamina on either side, right? In between, on either side, between the pedicles, you have a foramen which helps transmit the nerves of that level. It's called the intervertebral foramen. And it's also important to identify this is just like this is a coronal section. There are various parts of the canal. Compression at different parts of the canal will give different symptoms. Now, the center of the canal, we call it the central canal, is occupied at the lower level by the cauda equina. At every level, we have two nerves. One nerve, which corresponds to the upper vertebra, has already exited from the neural foramen. So that just leaves immediately below the pedicle level, which I can show. Now, that is called the exiting nerve root. So the exiting nerve root at L4, L5 level is the L4 nerve. So that does not come into contact with the disc. That is, you got to remember that. The other nerve, which has left the cauda equina, travels a little distance and leaves at the lower level. So that is the nerve root which corresponds to the lower vertebral level. That is called the traversing nerve root. Now that is a nerve which overlies the disc. So let's say, for example, you have a disc prolapse at L4, L5 level. They can either compress the cauda equina in the center or the traversing nerve root. So an L4, L5 disc prolapse will have symptoms of L5 nerve root, not L4. But if you have a disc prolapse at a far lateral part, which we call is the foramen level. So the foramen is three-dimensionally the region which is between the two pedicles. That is occupied the exiting nerve root. So that will give symptoms of exiting nerve root symptoms. And you also can have far lateral disc prolapse, which again can compress the exiting nerve root. So this is very important to have an idea about where the nerve root lies and what compresses. So this is a classic example. For example, let's say there is a more often we see discs at the center or the posterolateral border. So this is in the lateral recess. There is a disc prolapse between L5 and S1, which is compressing, as you can see, the S1 nerve root, which leaves the S1 foramen. In contrast, if you have a disc, far lateral disc, it is outside the zone of the pedicle, and that is compressing your exiting nerve root. So to understand pathophysiology, now what happens is like when you have degeneration. So I'll go into the next slides and explain you what are the elements of degeneration. So this degeneration will cause some kind of a dysfunction in moving body parts. It may be related to the spine, the vertebral column, or any large synovial joint like the knee and the hip. So this dysfunction will cause some degree of instability. So there'll be irregular movements between these elements. So what is the nature's response to stabilize it? Is by forming a lot of bony spurs and trying to bridge these moving elements. Now, if there is instability between these two vertebrae, let's say it's L4 and L5, there'll be a lot of processes, bony spurs, which try to link the joints between L4 and L5. So always remember, so there are, in simple terms, there are three joints between each vertebra. Anteriorly, you got the intervertebral disc. Posteriorly, you have two facet joints. So between these joints, there will be a lot of bony spur formation, which we simply call osteophytes, which you see in other joints also. The purpose of these bony spur formation is to link and bridge the two bones and stabilize it. So this is the natural mechanism, but this doesn't go smoothly. As a result of this pathological process, you have a lot of neural compression. Now, this was described by a couple of people called Kirkcaldy and Willis. This is what we still believe as an hypothesis. So there are two elements of the joint. Anteriorly, you got the intervertebral disc. Posteriorly, you got the two facet joints. So all the degeneration eventually leads to some instability. So when this happens, this instability will cause compression of individual nerves, and eventually they will also cause compression of the central element, which will lead to spinal canal stenosis. Initial instability will cause individual nerve root entrapment. And finally, all these processes, bony spur formation will, which is the means by which the nature tries to stabilize your spine, will give rise to central canal stenosis. So if this happens in so many different levels, you will have multi-level spinal stenosis. Just to have a bit of an idea. So what happens is, most often what happens in the disc level is disc degeneration. It's with time, the content of water in your annulus fiber, the nucleus pulposus will diminish. There is a lot of alteration in the cells and in the biomechanical milieu. So when this happens, when the disc degenerates, the height of the disc will reduce. This is what we quite often note even in X-rays, the reduction in disc height. And this will cause the disc surrounding, which is the annulus, to buckle inside the canal. This reduction in height will put an abnormal stress into the posterior joints, which is the facet joints. And when they are caused, then they are being stressed out so much, there will be osteoarthritis of the facet joint. So what are the features of osteoarthritis elsewhere? It is hypertrophy, osteophyte formation, and the whole facet joint become very bulky. One important feature in degeneration is, as a consequence of all these, the ligamentum flavum, which is what connects the two lamina at the back, will hypertrophy. They can go up to, this a thin layer, which can even increase to a size of about 1 centimeter thickness. And then that will buckle into the canal and cause compression. Eventually, the spinal segment will become unstable. It will slip either forward, which we call spondylolisthesis, or they can slip backwards. So this is classically what happens. You can see on one side, we have the normal spine cross section. On the other side, we have a stenosed one. Now look at all the changes. Now on the right side, you can see there is a lot of fissuring in the annulus, makes it weaker and thinner, and the nucleus pulposus bulges back and it encroaches into the canal. And at the back, you have the facet joints. Compare the two sizes. It's very bulky. There is a lot of osteophytes. These are osteophytes. And they also encroach into the foramen in the lateral recess and in the center. And importantly, you can see with comparison with the other side, the ligamentum flavum is quite thickened, and that also causes compression. And you can see well spread out nerves here and compressed nerves here. So this is again a manifestation of the different parts of the canal. It's very important to have an idea about what is central part and what is lateral recesses and what is foramen. So whatever is in the center occupied by the Cauda equina is the central canal, where the traversing nerve root lies. Whatever is medial to the pedicle is called the lateral recess. This is zone 2. What is in line with the pedicles, where the exiting nerve root line, is the foraminal space, and you have the far lateral space. How do they present clinically? Now, this all boils down to where the compression happens. So based on where the compression happens, you have broadly two types of symptoms. Now, in our setup, it is very hard to acquire a history, a proper spinal history from our patients. If you go to the West, their presentations are extremely textbook. But in our setup, you have to extract the details from the patient. I will tell you some of the tips which I use along my period of experience, what I do. Now, so broadly, you have two types of symptoms based on where it compresses. If there is a lateral recess or foramen compression, that is where the nerves lie, you have what we call radicular symptoms. This is the type of pain which, like, classically you call sciatica. These are shooting type of leg pains, and it may terminate depending which nerve compresses, and you may have numbness along the distribution of the nerve corresponding to its dermatome. Now, if you have central canal stenosis in this region, all right, they are the type of people who present as neurogenic claudication. So you've heard a lot about neurogenic claudication, and you also have heard about vascular claudication. And often what is checked is whether you know the differences between the neurogenic claudication and vascular claudication. Okay. So how do we understand? Now, if you ask, before that, now, if you ask, most of us ask patients present to us with back pain. Now, they never come along with their leg symptoms. Now, often if you ask them, whether the back pain shoots along to the leg, they will say yes. But in some of them, what happens, some of them have true radicular symptoms, but some of them have back pain and osteoarthritic knee pain. They perceive that as a leg pain. So you got to properly ask them whether this is actually shooting type of leg pain, which radiates from their buttock along their thigh to the calf. All right. Any pain beyond L4, L4, L5, S1 has to radiate below the level of the knee. All right. Neurogenic claudication, on the other hand, this is a type of vascular claudication. Typically, patient present with calf pain, which happens with amount of walking. And once the patient stops mobilizing or stops, the pain relieves, and it is reproducible. When the patient walks along same distance, he produces the same symptom. In contrast, neurogenic claudicants have a lot of discomfort even with standing. So that's pain with standing. So claudicants come with severe back pain. And if you ask them whether that is leg pain, they will say no. Then if you ask them, can you walk and stand? They say absolutely not. Because they cannot explain what's happening in their legs. Because what happens is when you're standing and walking, they have a lot of pain, also weakness of the legs. They can't stand up and the legs turn quite numb. In Western books, they will mention that leg turns jelly. So our patients find it very hard to explain. So you got to sort of extract it from them. And also they will say when you walk and the pain is produced, stopping will not relieve the pain. So they keep on walking. That is contrast to vascular claudication. Also, what is different from vascular claudication is different postures relieve their symptoms. For example, cycling, and especially this phenomena called shopping cart syndrome. Okay. Why does that happen? Is because now I mentioned to you previously the ligamentum flavum. The ligamentum flavum is like the covering of the spinal canal, which connects between the lamina above and lamina below. Now, when it hypertrophies, it has a tendency to bulge into the canal. When a patient is stooping forward, like when you're sort of holding on to a shopping cart, the distance between these two lamina will increase and the bulge into the canal will diminish. So there will be some relief in the diameter of the spinal canal, which will relieve her symptoms. That is what is called shopping cart syndrome. So they will find it easy to stoop forward, any movements which they do with bending forward. Clinically, when you examine, always remember to exclude concomitant cervical myelopathy. As I mentioned before, your cervical spine and the lumbar spine are the mobile parts of your spine. When degeneration happens in one, there is a likelihood that you may have degeneration in the bow. And I will tell you in my subsequent slides why it is more important to relieve cervical myelopathy first before lumbar compression. And check for the upper limb neurology and evidence of myelopathy. Examine the back, its movements. They'll be quite sluggish with the pain. Look for the stretch test, like what we call straight leg racing test, which is often positive with acute condition, like an acute disc prolapse. Check the lower limb neurology, tone, power, reflexes, and always complete it with a digital rectal examination to check the pinprick sensation and the anal tone. So it's very important that you always check for concomitant cervical myelopathy and lumbar stenosis and address the neck first. This is very important. So this is basically because, let's say if you have compression simultaneously in neck and back, this often happens and because certain percentage of people with degenerative spine disease have a silent myelopathy, but they present with their leg symptoms because this is what involves a lot. So if you happen to address the lumbar spine before the cervical spine, this may have very bad consequences. As you know, the cervical spine and the thoracic spine are upper motor neuron. And the lumbar spine, the Cauda equina, below L1, L2 level is lower motor neuron. So the threshold to injury is quite low with upper motor neuron, therefore with the cord level compared to lower motor neuron. Any vascular problems, insufficiency, hypotension will more adversely affect the cord than the lower motor neuron. So when you're operating on the lumbar spine, we generally operate from the back. We put them in a prone position. We have to manipulate the neck, anesthesia, and the blood loss may cause hypotension. all these will adversely affect an already compressed spinal cord at the top level. So this patient may sometimes end up waking up fully paralyzed as a consequence of spinal cord injury. So you always have to make sure you check for concomitant cervical spinal cord myelopathy. Right. Imaging. So X-rays are the basic tool. So we cannot go into a surgery or any form of invasive procedure with just X-ray alone. But like in most of our setup, we will first go for an X-ray. What are the changes we look for? Look at the spine. So there is a lot of bridging osteophytes on this side. This is how your spine tries to stabilize yourself. We spoke in relation to the pathophysiology. And this may cause a sideway bend. It's called a degenerative scoliosis. And look at the end plates, quite sclerotic end plates. And this is another phenomena which you can notice. It's called spondylolisthesis. We are going again and again to spondylolisthesis. This is a forward slip as a consequence of the instability caused. Okay. Look at the disc height at L45 and L5S1. The disc height is reduced. And look at the marked whitening called the sclerosis of the end plate. These are also responses to the degeneration. And if you look at the back, so again, there is narrowed L5S1. If you look at the back, there's quite massive discs, facet joints at the back. These are also consequence of degeneration. Now, we speak about spondylolisthesis. There are so many types of spondylolisthesis, but like there are two spondylolisthesis which you will come across very frequently. The one we are describing today is as a consequence of degeneration. We call it degen spondylolisthesis. In contrast, the other variety is called isthmic spondylolisthesis. It is important to distinguish these two because they present in different forms and they need different treatments. Degen spondylolisthesis, which we will discuss today, will happen mostly in L4-5 level. And if you look at an MRI scan, it will classically present with stenosis of the canal. The canal will be encroached, like in our previous diagrams. And it's very unlikely to cause very severe degree of slips. In contrast, if you take isthmic spondylolisthesis, it happens more frequently at L5S1. Now, the reason is there is a region called isthmus. Isthmus is where, or we call it the pars, is where the lamina and the pedicle meets. This can either have an acute fracture or a stress fracture or some kind of a defect which you have inherited during your childhood. So this will cause the posterior elements like the lamina spinous process to remain where they are and the anterior element will slip forward. So in fact, what will happen to the canal is the canal will become bigger. It is the nerve roots which get compressed at the sides, at the foramen level. So they will not present with claudication. They will present only with sciatica type of radicular pains. Important to remember that. So MRI imaging is the image of choice. Now, this is the previous MRI showed of our patient. You can see classically what has happened. All I have described: bulky facet joints, unstable looking ones because a lot of water, thickened ligament and flavum. Look at this black mark at the back and on the sagittal, and you can virtually see nothing of the Cauda equina, all right? And the disc itself is bulged backwards also. So this is another important point. So because, as I told you, in elderly population, concomitant cervical myelopathy has to be excluded, it is important for us to do an MRI whole spine rather than just a lumbar spine in elderly people, because this is how we can detect asymptomatic myelopathy. I have met a lot of people who came with lumbar spinal stenosis, had an MRI, had cervical myelopathy, which is silent, ended up having neck surgery first and subsequently lumbar surgery. The problem is, if you do an MRI spine in everybody, elderly, most of them tend to have some kind of a changes, but not all these changes will clinically correlate. Now, there's one paper I found presented by Borden. He had evaluated 67 asymptomatic individuals who are above 60 years. They showed about 57% showed some abnormal degenerative changes, and about 1/5 showed gross spinal stenosis. So asymptomatic spinal stenosis is very common. So unlike asymptomatic cervical myelopathy, is not very significant to address asymptomatic MRI findings in the lumbar spine. I'll tell you why. So other investigation, you can do flexion extension lateral X-ray to check whether whether the level is unstable. CT myelogram. Now, some of our patients will not be able to undergo MRI scan for so many reasons. Claustrophobia is very common. They can have metal work in their spines or elsewhere, which cannot be removed. Therefore, they will have to undergo CT myelogram. The problem is it will show you obstructive pathology, but it will not show anything, whatever is wrong with the neural element. Neurophysiology has not got a place, significant place like in cervical problems. It is important when when you have leg symptoms and you have excluded with an MRI. I quite often do it to exclude or look for any other potential causes which can mimic lumbar radicular symptoms. For example, something like piriformis syndrome. As you know, your nerve root, the sciatic nerve, when it comes out, it goes to the two heads of the piriformis in your buttock. If you have tight piriformis, it can sort of reproduce the leg symptoms when people sit down and compress on their sciatic nerve. And you can have other causes of neuropathy, which will be helpful. So now it's very important to identify what happens if you do not treat lumbar spine. If you had been to my previous lecture on cervical spine, the natural history of cervical myelopathy or cervical cord compression is that there will be progressive deterioration of the patients in a gradual or step-ladder fashion. That is what I wanted you to remember from my previous talk. But in contrast, if you take people with lumbar stenosis, vast majority will remain unchanged. Well, they will have the symptoms, but they would not progress. So this paper noted that about 15% will improve and that 15% will worsen. This is a very old paper presented in 1993. Okay. So what do you do to them? So management-wise. All right. So simply all of us will initially try to manage these patients with analgesics. Okay. And then course of physiotherapy. Now, if that does not work, we also try corticosteroid injections. Now, all of you might have heard epidural injections. Now, there is two ways of giving, administering an epidural injection. One way is like what you do a classic lumbar, like a sort of a spinal injection between your lamina. Or what is frequently used in the West and what we used to do now is what we call a transforaminal steroid injection. That is a very specific route targeting not the whole nerve bunch, but a specific nerve, and which evidently has very high advantage and very high satisfactory rate compared to interlaminar injection. So interlaminar is like what routinely is being given by the anesthetist and most of our colleagues, right? So how do we do a transforaminal epidural steroid injection? I'll tell you how I do it. So I do it under fluoroscopy, or we call it C-arm inside the theater. And it can be done under CT guidance. Our radiology colleagues do it under CT guidance. I use a 22 gauge spinal needle. Per level, I infiltrate with 0.5% 1 cc Marcaine or bupivacaine, along with 40 milligram of triamcinolone per level. The problem of using 0.5 in comparison to 0.25 bupivacaine is like you tend to have a bit of a motor paralysis, just like a spinal anesthetic, and it may be a bit irritating for the patient. So it will take a little time for the patient to recover and walk again. The risks are very, very infrequent. Sometimes I've reported cases of CSF leak, which again, when you make the patient lie flat, have some coffee, tends to resolve within 24 hours. You also have to advise the patient that there can be a transient worsening of the pain. Some people's nerve roots tend to irritate because of the steroid. Then they can have worsening of their leg symptoms. You have to reassure them just to take some pain relief, and then it will resolve. So recurrence is another possibility. So it all depends on why you inject it. If it's an acute disc prolapse, if you inject it, by the time the effect of your steroid injection wanes off, the disc might resolve. But if you inject to chronic causes, like in sort of lumbar canal stenosis, degenerative, there is a likelihood that the symptoms may recur back again, perhaps in 6 months or 9 months. Choice of steroid depends. You can give methylprednisolone. I use triamcinolone. Newer evidence suggests that dexamethasone may be superior to triamcinolone. The most important thing is it's not effective in claudicants due to central canal stenosis. It rarely responds. So for them, unfortunately, the best mode of treatment will be surgery. So I've always mentioned about the two routes of providing epidural injections, the translamina or interlaminar procedure or the transforaminal procedure, which we practice. So there is a comparison paper comparing these two procedures, which there are quite a few papers. So this paper also denotes that the transforaminal injection shows a better short-term pain improvement and a fewer long-term surgical interventions requiring than the interlaminar epidural steroid injection. So that's quite evident. In the West, it's actually the transforaminal injection which is used, not the interlaminar. So this is how I do it. I take the patient to the theater. I make him lie on his tummy, prone. It can be done under local anesthetic, so I can mark the place where I'm going to inject and just infiltrate a little bit of a lignocaine and then inject it or pass the 22 gauge needle, or you can give a mild sedative also. So this is the C-arm or the fluoroscopy machine. And once I have positioned the patient after cleaning and draping, I try to visualize where I am inserting my needle with a AP and lateral X-ray. Sometimes it's easy to have an oblique X-ray. People who have a radiology knowledge would know you can have an oblique weave of the lumbar spine, which sometimes helps me to insert a shorter needle. Once you have confirmed the position of your needle tip with the AP and lateral X-ray, you can further confirm that you're in the right place by injecting some contrast, which is called the rotogram. When you do the rotogram, now you can classically see this is the pedicle, immediate pedicle. You can see the exiting nerve root, and it also highlights the traversing nerve root. Once this is done, you can give the injection. So our unit experience, we did quite a few, but we managed to evaluate. And unfortunately, once the patient has symptoms have relief, they don't come back. So we only managed to gather details from 28 patients. So these are evaluated, but not these are unpublished data. So we monitored them minimum 6 weeks, and then we assessed their pain intensity using the Vasco separately for the back pain and the leg pain, pre-procedure and minimum 6 weeks after the procedure. And the degree of disability, how much of disability in terms of their daily function they are encountering. This is the best tool to assess that is something called the Oswestry Disability Index. We call it ODI. So what we noted is at 6 weeks and after, the leg pain Vasco, not the back pain, the leg pain Vasco and the disability assessed by the ODI showed significant improvement compared to pre-procedure scores. Finally, surgery. Right. So is surgery effective? There is a lot of myths, controversy, and especially in our country, misbeliefs and fear of spinal surgery. There is a lot of misinformation which has been transmitted to the patient. And the first thing they will ask you when you offer them surgery is, will I be paralyzed? Unfortunately, I think we all have to be blamed because of this misinformation. Spinal surgery is so advanced and has come forward now. Paralysis, as what is feared in the society, is unheard of. So it's important for you to know first whether somebody will benefit from surgery or conservative measures. So this important trial, there was various stages of this trial called the SPORT trial. The abbreviation, when you extend it, it means Spine Patient Outcome Research Trial. So this was a multi-center randomized trial where people were randomly allocated into a surgical arm and a non-surgical treatment modality for patients with lumbar stenosis without spondylolisthesis, without any instability. So they checked with the primary outcome measures, they checked were the bodily pain, the back pain, and the leg pain, and the physical function and the disability using the Oswestry Disability Index. And it concluded with no doubt that surgery causes significant improvement in all primary outcomes compared to non-surgical cohort. So in terms of surgery, what do we do? Now, traditionally, all of you would have heard laminectomy. We've moved forward, and especially in the West, and most of us, what we practice, we try not to disturb the whole lamina. I'll tell you why. That has a lot of relevance on the patient's outcome and subsequent mobility. What we do is what we call a segmental decompression. We do only a laminotomy and to decompress only the nerves, leaving the whole midline intact. So what do we do? So this is the model of your spine. As you can see, this is the back of your spine, transverse processes, facet joints, and this is the spinous process. So the spinous process at this level is completely removed. The lamina is completely removed. It's called a laminectomy. And this is the ligamentum flavum. It's completely removed, which also causes compression. This is the standard laminectomy. So that can be done on either side. You can remove both the lamina on the left and right, or you can do what we call is a hemilaminectomy, or remove the lamina only on one side. So in contrast, what we do now is a limited decompression to relieve the central part of the cord and the lateral recess. So we leave the whole midline intact, the spinous processes and the interspinous ligaments. I'll tell you why in my subsequent slide. So as we have noted earlier, ligamentum flavum is one important factor which causes compression. So we detach it by detaching it from the lamina above and the lamina below. So you don't have to take the entire lamina off. You have to take only a little bit. We can take a little bit of the facet. I told you in the pathophysiology, the facet joint, which is hypertrophied, encroaches into the canal and take off the lamina. That will completely relieve the compression on this half of your central canal and the lateral recess. You can follow this nerve root and decompress its surrounding. So you can use a microscope to visualize all these things, which will cause a very minimal disruption of your midline elements. You can repeat this on the other side and relieve the entire canal of its compression. So it's quite simple. So comparison between the traditional laminectomy versus the midline preserving decompression. So when you do a laminectomy, there is more dissection, more blood loss, more post-operative pain. Importantly, when you disturb the midline structures, it will cause a degree of spinal instability and it will alter the balance, a sagittal balance, which we discussed earlier. This will relieve the patient's leg symptoms because you have decompressed the nerves in the spine. So the leg symptoms will have resolved. But because you created the instability of your spine, there will be persistent back pain and exhaustion with walking. So this will essentially limit patients' mobility. So this have noted to have a poorer post-op outcome compared to our midline preserving techniques. So this is another study which had compared the posterior decompression techniques to the conventional laminectomy for lumbar spinal stenosis. This overwhelmingly concluded that performing limited decompressions without conventional laminectomies, patients had better functional recovery. They had good post-operative stability, so they mobilize well immediately post-operatively. You don't have to even use a brace. I don't use braces at all. And the post-operative rehabilitation outcomes are pretty good. So you got to know a little bit about all our degeneration happens because of the balance of our spine. So in general, what should happen is when we stand still, our center of gravity should directly go through our spine and fall between our 2 feet. So if you take a long X-ray and draw a line, a plumb line, or a sort of a perpendicular line from the C7 vertebra, it has to go slightly closer to the tip of the sacrum. What happens is our tendency always is to tip forward. The center of gravity is to tip forward. What prevents that is all our structures at the back of the spine. So notably, these are the spinous processes, interspinous ligament, the muscles, all are very helpful. Now, it's very important for us to keep an upright posture. That is why initially we recommend a lot of back strengthening exercises. So you need a lot of powerful muscles at the back to keep your upright posture. It is better to be upright rather than being stooped forward. That is what leads to a lot of degeneration. Now, this entire posterior structure, if you can remember from your skull base, it extends all the way down up to the sacrum. So at the top part, you got the ligamentum nuchae, interspinous ligament, all of these connect as one single structure to the back. So what happens is if you have to do a laminectomy, you rip off the spinous process at the back. This will disturb our sagittal balance, and there will be a tendency for you to stoop forward. When this happens, it is not energy efficient to the muscles at the back. So you go into premature exhaustion. Your mobility, post-op recovery will be really hampered because of conventional laminectomies. So you also can perform, you can put metal work. So if you, when I discuss about the topics, so if there is any disc prolapse, you can take the disc off. So you're basically your plan is to relieve the compression of all the nerves, right? And if there is instability, you can put metal work, right? You can put rods, screws, and all forms of things and prevent its progression. So for example, if you have spondylolisthesis, that is one bone slipping on top of the other, so that is a degree of instability. So what you do is if you have concomitant spinal canal stenosis, if you do a laminectomy or some kind of a procedure at the back, this will further destabilize. Remember the two joints at the back, which stabilizes the spinal level. So to prevent that, you might have to put screws, rods, stabilize it, and then do the decompression. Okay. And it has quite evolved. We also can do with a very tiny cut. We'll call it the MIS or minimally invasive system. So you can put a tiny cut on one side of your back, enter progressively large funnels, and through this, and after visualizing through the microscope, you can do a decompression of the same side and through the same incision on the opposite side as well. So I'm not going to do any comparison between these studies, all right? So also what we currently also do is like endoscopic decompressions and discectomy. So there is a place where to do endoscopic and there is a place where to do open procedures. So what are the complications of surgery? So bleeding and infection are frequent. So nerve injury is the most catastrophic. So gross paralysis of the leg is the prevalence is extremely rare. But what you can have is individual nerve roots can get damaged, harmed, or temporary dysfunctional. So depending on the nerve which is involved, you can have symptoms. For example, let's say your L5 nerve root is affected. You may have foot drop or weakness of your big toe. You also may have loss of sensation. Rarely, if your whole cauda equina is insulted by some means, you may have loss of sphincter functions and sexual function. What is more frequent is dural injury. So in the West, the standard percentage of dural injury is about 3%. So dura is what covers your nerves. So it's covered, the whole thing is bathed in CSF. So if you have any dural injury at the time of the surgery, we can repair it. But if it goes unnoticed, there will be persistent CSF leak. So post-operatively, patients will come with an unhealing wound because of a discharge or because of the CSF pressure, they can have headaches. So what we tend to do is keep them flat bed rest for a long time, for a day, 2 or 3, and allow the wound to heal, and automatically the CSF tends to heal off. Wound complications are again somewhere in the range of about 1%. So there can be implant failure if you use metalwork. Now, it's very important when you do spine surgery through, increasingly our incisions are becoming very tiny, and the work that we do at the back is very tiny. So we potentially leave only very small room for the nerves. So if you don't achieve good hemostasis, if there is persistent leaking, there can be a subsequent hematoma which causes cauda equina compression. So you may have to drag the patient immediately to theater overnight. Now, all these procedures are done in the prone position. This will cause some degree of head dependence. So there can be some pooling of blood in the cerebral vasculature and an element of reversible cerebral edema. Especially in the elderly patient, when they wake up, sometimes they may be a little bit confused. It is also reported. Before we conclude, I thought I will also touch upon a little bit about Cauda equina syndrome. Now, Cauda equina syndrome, unfortunately, is given less emphasis in our country, but it is a reason for very high litigation rates in the West. There is absolute fear in the West for Cauda equina syndrome. If you actually look, the incidence of CES is reported in the West, especially in the United Kingdom, is 0.07% to 0.12%. It's so small. But the amount of MRI scans done per day is, so amount of litigation is extremely high in the West, that despite the very low prevalence incidence, there is a large number of MRI scans done to catch that potential rare Cauda equina syndrome, right? So by definition, what is Cauda equina syndrome is the compression of lumbar and sacral nerve roots resulting in dysfunction. So the feared consequence is loss of bladder, bowel, and sexual function. It is more commonly due to an acute cause, like a large central disc prolapse. So what most of the people do not know is that broadly you can categorize Cauda equina syndrome into two groups. One is called the CESR, or Cauda equina syndrome retention, or the other is the Cauda equina syndrome incomplete. So the patients with CESR are the ones who come with what you know classically with bladder retention and incontinence because of overflow. So this is what is sort of enshrined in our minds. This is what Cauda equina syndrome is. And we really panic with this. The other variety is Cauda equina syndrome incomplete. This is where people say that, intermittently their voiding sensation is lost. They cannot feel that they are passing urine. They lose the desire to pass urine, but when they go to pass urine, they can pass a lot of urine. Or sometimes they have a very poor stream, and at the end of the stream, they feel that there's more bladder. So this is what is extremely important, CESI, because the people who come with Cauda equina syndrome retention have already lost the function of the Cauda equina. And whatever you do, the chances of recovery is extremely slim. But most of the litigation in the West happens with this entity, Cauda equina syndrome incomplete, because it is a reversible condition. And the quicker you address, you have to take them to theater overnight. So most often it happens at L4-5 and L5S1. So I've told you that this is an acute situation. Could this happen in patients who have chronically stenotic canals? Now, if you remember, we discussed about central canal stenosis, and the previous MRI scans I showed you shows absolutely no room for any nerves in the center in chronic degeneration. Is that Cauda equina syndrome? No, it is not. Because in those patients, the Cauda equina is like compressed along the period of a long time. So it is sort of adapting to it. But they also can go into Cauda equina under that environment. If you have an acute disc prolapse, even the smallest disc prolapse, that can change the milieu. They can go into an acute Cauda equina syndrome. So how do they present the clinical syndromes? So grossly, they can have dysfunction, bladder, bowel, or sexual function, or the incomplete variety. They can have sensory changes. They tell you that they have numbness in their private parts. Some of them, when they pass twos and when they are trying to wipe their private parts, they don't feel the sensation. There are other possible symptoms. They come with back pain, leg pain, always worry when somebody comes with acute bilateral sciatica. Now, as you can remember from the initial part of our lectures, most of the disc prolapses happens at the center or the posterolateral part. Now, let's say if you have a lateral disc prolapse, you will have one nerve root compressed, which will cause unilateral sciatica. If you have both legs, it's unlikely to be two discs on the either side. It's most likely to be a very large disc, which is compressing both nerves on either side. Therefore, it must be compressing the cauda equina significantly. So somebody coming with bilateral acute sciatica, be very warned. So they also can come with sensory changes in the lower legs, weakness of the legs, reflexes can be low. So unilateral, bilateral symptoms. So once you have done your stretch test and all these things, it's very important to do a thorough PR examinations. So what I instruct all my juniors to do is this. So first you got to check the perianal pinprick sensation. The dermatomes around the anal verge is arranged like an onion ring, S3, S4, S5. These are very important. So you take a toothpick and prick them and see whether the patient can distinguish sharp from blunt. So if the patient can distinguish sharp from blunt, you give 2 by 2. If the patient can feel the touch, but it cannot distinguish whether it's sharp or blunt, it's 1. And if it doesn't feel anything, it's 0. So any deviation from a 2 by 2 is significant. Look at the anal tone. You can check his resting anal tone and voluntary anal tone too. Bulbocavernous reflex. If you can remember, if you put one of your digital, when you do a DRE or the PR examination, if you compress on the bulb of the urethra, once you have passed the catheter, you can pull on the catheter. The catheter bulb will compress on the bulbar urethra. That will elicit a response by contracting the anal sphincter. This is a primitive response. So if this is lost, this is very significant. In places where you don't have an MRI, just to have a brief idea, you can do what we call as a bladder scan. So how do you do a bladder scan is you ask the patient to sort of wait until the bladder is full after drinking water. Once he has the urge to pass urine, you do a pre-void scan and make sure that the bladder is full. And then ask him to pass urine and you do post-void scan. So any value of less than 200 milliliters, it's less likely to be CS, but it does not completely exclude it. So don't be really assured if it's quite less. So the value 200, 100 is very debatable, but why there is no significant amount of studies around it is because it may give a false sense of assurance. But in a peripheral setup, if you do a bladder scan, if you have it more than 200, if you have patient does complain, some symptoms are suggestive of incomplete cauda equina, be alarmed, get instructions or spinal surgical intervention as soon as possible. So how the MRI? So it's very, they urgently need an MRI scan. So you've got a very large disc prolapse at L5S1, which is completely effacing all the nerves and feeding in the central canal. So they need to go to theater urgently. There is a lot of work and studies done about the timing of surgery for Cauda equina syndrome. Unfortunately, it's very controversial, basically because lack of evidence due to ethical reasons. Now, you cannot put them into two arms where one set of people are offered surgery early, another set of people are not offered surgery early, because it would be unethical. But when you go through a lot of literature, the general consensus is if somebody has Cauda equina symptom incomplete, they require immediate surgery. If somebody has Cauda equina syndrome retention, overflow incontinence, as I told you before, the chances of recovering their Cauda equina is very slim. So they may have surgery on the following day. So there are a lot of studies where they have done even patient with retention, CES retention before 24 hours and after 24 hours. So they have concluded that it's better to have it before 24 hours. So I'm not asking you to delay them days and days. Don't go home with that idea. Anybody who's coming with incomplete Cauda equina syndrome, it's better to do it urgently. Because of lack of evidence, to give the benefit of doubt to the patient, we do them immediately as possible to give them even the slimmest chance to recover. Because having a catheter or having to self-catheterize, losing a sexual function, especially in a young adult, may be quite devastating. So but unfortunately, if somebody does come with incontinence, it's a poor prognostic feature. This factor is very important for you to advise patient, especially regarding their outcomes. Because if they have a false sense of assurance that they are going to recover fully, and there may be cases of litigations because of this miscommunication. So beware. So finally, this is my last slide. All right. So this whole thing about degenerative back will eventually come to a point where what do I do with patients who come with back pain? It's extremely common in every setup. You need to have a sort of a working algorithm in your head. All right. So broadly, I would say my way is to first make sure that the patient, so the vast majority, more than 95%, will be degenerative back pain, which you cannot have a permanent remedy to, right? So degen is part and parcel of our aging mechanism. We cannot reverse it. It's just like osteoarthritis of your knee and all these places. This is inevitable. But what you have to identify is whether this patient is having any sinister causes, like it may be cancer, primary or secondary cancer, or whether this patient has any infection. It can be pyogenic bacterial spondylodiscitis, or in our countries, very common is tuberculosis, or whether this patient has any fracture. So these are sinister causes, right? So we have a set of red flags in back pain. So in GP setup in the UK, you will be given a sort of a list of red flags to exclude potential sinister causes which may present as back pain. So you got a mnemonic you can remember is tuna fish. So trauma, any patient with trauma, suspect of fracture. Unexpected weight loss, think of cancer. Neurological symptoms, problem with the rising neurological symptoms is you may need immediate intervention in order to reverse neurological symptoms. So they may need urgent intervention. Age of 50, as I mentioned, the sinister cause will be more common in patients with more than 50. Look for fever and IV drug users. So conditions such as spondylodiscitis may be present in these subset. Steroid use can result in pathological fractures, osteoporosis, and look for history of cancer. So any of these, you may need further evaluation. And once you have excluded sinister cause of back pain, think about neural compression symptoms like we discussed earlier, leg pain, claudication, where you can address surgically and by some means to relieve the patient's symptoms. So once this is all excluded, that is when we think this is just degen back pain. Then we can go into sort of your conventional treatment modalities like analgesics and physiotherapy. So this is a very important slide. So I hope I have given you enough information. So try to keep it as brief as possible and as concise as possible. So that concludes my lecture. Thank you.
So there are several questions in the chat box. The first question is, what is the importance of straight leg raising tests in back pain patients?
Okay, so this is very important. So what happens in straight leg raising is that one of your nerve root is compressed and you're trying to stretch it. So sciatica is L4, 5, S1, S2, S3. So you got the L4, 5, S1 nerve roots which come down. So when you raise it, it has to cause a reproducible leg pain when you raise it to about 30 degrees. All right. Now, our degen entity, patients, now I mentioned it, SLRT might often be positive in acute disc prolapses. But if you take patients with chronic compression causing radiculopathy, SLRT is quite often negative. So, well, it is just supportive evidence, but it does not help you to go along with symptoms. Now, if you take the acute element, so most of the people come with acute sciatica, you got to know that most of them are due to a disc prolapse. It's very common in our society. Before running into conclusions or making, doing MRI scans, which is very expensive in our country and which is not available routinely, you got to first identify. So you got a straight leg raise test. Don't panic. Think few things. First thing is just make sure that this patient does not have Cauda equina syndrome if it's an acute condition, right? No Cauda equina syndrome is relieving. So because if you have an Cauda equina syndrome, the patient needs to undergo immediate intervention. Second thing is, along with the sciatica or shooting leg pain, does he have motor weakness? If you have motor weakness, the evidence suggests if you intervene early, there is a chance of recovering the motor function. But if the motor weakness has been there for a long time, the recovery is unlikely. So if you, along with the sciatic leg pain, positive stretch test, if you have motor weakness, then they may need immediate intervention. All other patients, you think what will happen to the disc. Generally, what is known is about 75 to 80% of the acute discs will settle in about 3 to 4 weeks. So what I do is, if some patient comes with sciatica, no Cauda equina syndrome, no motor weakness, no neurological deficit, I just give them some good analgesics for about 3 to 4 weeks and reassess. So if somebody has symptoms beyond 3 to 4 weeks, the chances are that they may need some form of intervention, some like injections or surgery or whatever. So wait until such point. So SLRT in itself does not lead you to any conclusions or does not give you any indications of prognosis. So in chronic conditions, SLRT is quite often negative. I hope that helps and answers your question.
Yes, another question is, what is the place of chiropractic manipulations in patients with lumbar radiculopathy?
Okay, so my personal experience is, so as I told you before, like now patients who come to us with radicular symptoms basically have exhausted all their conservative measures, to be honest. Now, the important thing is, in comparison with other conditions like cervical myelopathy, lumbar stenosis is extremely rarely going to lead you to paralysis. It's unheard of. So what will happen is you will suffer with leg pain. All right. So it is the patient's desire to get a permanent remedy. Now, so they will inadvertently go into chiropractic, they will go into physiotherapy, native treatment, and all of it. So it's fair enough. But when they exhaust this, they will come to for some kind of a immediate. So I'm not asking people not to go, because it's okay to, I mean, as I mentioned before, if you check our previous study, about 15% will improve. So you give the benefit of the doubt to the patient. If it does improve, it doesn't need any invasive method. So I'm not the expert to say whether chiropractic works or not, but if somebody wants to go for alternative medication to try out, that's okay. But like if when they do exhaust, we know for a fact that there's good evidence that surgery will relieve their symptoms, and the chances of recovering is quite significantly high. What the paper suggests is about 90 to 95% of them relieve their leg pain, not their back pain, but their leg pain is relieved. So it's very good rates in terms of surgical relief to your leg pain symptoms.
Is there any role of vitamin D and multivitamins, and is there a place of benzodiazepine and baclofen for symptom relief with any short-term relief with oral dexamethasone?
Well, right. It's frequently practiced. Okay, so vitamin D. Now, with the vitamin D and has any role in degeneration? Obviously not. But obviously, we do know the fact that even the endocrinologists will accept with me is that there is a lot of vitamin D prevalence in Sri Lanka at the moment, contradictory to what we thought earlier. But that does not essentially lead, there is no evidence at the moment to suggest that vitamin D deficiency leads to degeneration, and that vitamin D will help you relieve your back or your symptoms. So just be mindful. I told you about the need to evaluate back pain, but essentially my lecture today was pointing towards radicular symptoms related, or leg symptoms, or neurological compression symptoms related. So That will not be healed definitely with vitamin D therapy. Well, gabapentin helps. We use gabapentin. So if you look at the West, actually they go into very high dose of gabapentins. So some people would recommend, the maximum accepted dose is like somewhere around 2,400 to 3,000 dose. But like none of our patients could tolerate that high dose. Like even with 100 milligram BD, they have quite bad symptoms with gabapentin. And the other problem is like when patients are on gabapentin for a long time, they have a lot of dependency. Now, neuropathic medication also works with people with radicular symptoms, not with claudicants. That is the most important. The claudication. So with radicular symptoms, I will give you a chance. Go ahead with your alternate treatment, physiotherapy, analgesics, chiropractor, or try everything possible. Unfortunately, with stenotics who present with claudication, it is uh, very hard to relieve any form of give them any sort of comfort with painkillers. So it's like when they come, they cannot walk. So when they sit, they don't have the symptom, but they cannot ambulate. That's the most important thing. So I hope it helps you. So analgesics can be tried. Dexamethasone is, I know it's frequently tried. Unfortunately, there is no evidence, and I don't use dexamethasone. So we have a lot of practice where when you have neurological functional deterioration. Now, we have a lot of people who still believe that when you have spinal cord injury and neurological compromise to give methylprednisolone. That used to be a famous trial, which has debunked now. There is no place for steroids in acute cord injury. The only place where I tend to give so local steroid tends to work. So if you have radicular symptoms, I told you we give a lot of foraminal injections. So we use a foraminal injection and we give steroids in the form of methylprednisolone. I use triamcinolone. So DEXA can be given. There's good evidence now emerging in the West that DEXA can be more effective than even triamcinolone in nerve root injection. But oral dexamethasone relieves your symptoms. Whether it will give any long-lasting effect? No.
All right. Sir, what is the place for applying external devices like lumbosacral corset as an option for non-operable elderly patients?
Very good. Very good question. So a lot of our people, when somebody comes with a back pain, offers them a corset. Now, if I is my slideshow still shared?
Yes, sir.
Okay. Now I will bring you to this current concept of this slide. All right. So now it's the current theory that the shape of your spine and the balance of your spine is what leads to a lot of degeneration. So you can postulate what kind of degeneration, what kind of spinal defect you will end up based on your shape of your spine. Now, what is very important is where your center of gravity falls. Now, I mentioned your center of gravity should travel along your spine. In ideal terms, it has to fall between your 2 feet. So naturally, we always have a tendency to lean forward. So when we lean forward, your muscles at the back has to hold on to it and pull it backwards and put extra effort. So when we do physiotherapy, most of your physios will encourage strengthening of the back muscles. That is one way of relieving your back symptoms. It's very important because none of us do any exercises to our back. So what in the West, what we say is the core muscle, which includes the back and the front muscles. So because it's the back muscles, which is the workhorse, which has to pull your spine and keep it upright. Now imagine what you do when you put a brace. You are artificially, you're maintaining your spine straight. What will happen to your muscles? It'll become more weaker. And then you will go into a cycle of dependency and further pain and reduce ambulation because of this. So I would strongly not recommend. I would rather recommend doing good physiotherapy and helping to strengthen your core muscle, which is the abs and the back. Right.
All right, so there's one more question.
Yep.
In a rural hospital, if we suspect a Cauda equina syndrome in acute setting, what measures should we take?
Transfer immediately. Because as I told you, time matters. All the litigation in Cauda equina in the West, even if it's coming in Sri Lanka as well, all is related to timing of surgery. So actually the timing of surgery is not the time the doctor attended to the patient in the West. It's not the time which took you to do an MRI scan. It's not the time which you took to take the patient to the theater. It's the actual decompression. So you give the patient anesthetic, you cut open the patient, take the laminar off, and part the cord, take the prolapsing disc out. That is the point where the patient's cauda equina is actually relieved. So in the West, it goes up to that extent. So the time matters, seconds matter. So as I told you, the most important thing is to your take-home message is there is two entities. When somebody comes, so don't ignore patients who just say, I got some buttock anesthesia, I got, sometimes I can pass urine well, but sometimes I don't feel it. So this is the alarming symptom, not the gross retention and overflow. So whenever you come across them, do a PR, as I told you, just evaluate them, document them, and inform your nearest tertiary care hospital and transfer them. It's very important. So these litigations might end up coming to our country also very soon. We all sort of, embrace whatever is in the West, unfortunately. So once this comes, documentation, timing is very important. So it's important for you to sort of dispatch the patient as soon as possible.
All right, so I think we have answered most of the questions here, so we can conclude today's program. On behalf of all of us here, I'd like to extend a very heartfelt thank you to Dr. Shazar Hameed, Consultant Orthopedic Surgeon of the Teaching Hospital Badulla, for taking the time to share such an informative and a valuable lecture. And we appreciate the clarity with which you presented these concepts. Thank you again, sir, for your time, your knowledge, and your dedication.
Thank
So
you very
there
much.
will be, thank you, sir. There will be a link for you to fill in to receive the e-certificate for CPD points and the post-program assessment. Please be kind enough to fill it before 11 a.m. and submit that. Also, today we are concluding this session. We invite you to join us next week, same time, for another weekly Sunday webinar program. Thank you for your participation and have a nice day.